Welcome to Alpha Coding Podcast, an all-access pass to medical coding and billing pro tips that help you start your week off smarter. And now, here is your host, Toni Elhoms.
Hello, everyone, and welcome to the Alpha Coding Podcast series. I am your host, Toni Elhoms. Welcome to episode 67 of the podcast. Today is April 12th. And I just want to say thank you to all of the listeners out there. The download numbers have been amazing. I've been getting such great feedback from everyone. And I'm just really humbled and grateful to lead this community. So thank you for the opportunity. So today we're going to cover a topic that is trending in healthcare. It comes up almost on a daily basis in my consulting practice, and that's navigating remote patient monitoring, aka RPM, in 2021. So before we dive into our topic, it's time for your Monday dose of positivity, the Mindset Monday tip. And it's brought to you by Contempo Coding, which is an on-demand educational resource provider created for coders by coders. They specialize in affordable coding certification prep courses to help you accelerate in your career. Right now, they're offering an exclusive special to Alpha Coding Podcast listeners, and that's $125 off the Certified Risk Adjustment Coding Prep course, as well as some great bonus content when you order through our affiliate website. This course has a 100% pass rate, by the way. Visit our website, alphacodingexperts.com, and head over to the Deals and Discounts tab for a link to take advantage of this absolute steal of a deal. So our Mindset Monday tip is all about reaping what you sow. The quote I want to share with you says, "Words are like seeds. We plant them in ideas and people's minds. They must be watered with trust, respect, and authenticity to grow into action, results, and success." And I absolutely love this quote because it is such an important reminder. The words that we specifically tell ourselves have so much power. They plant seeds within our mind, and that then manifests into our own reality. So if you're constantly being negative and planting these negative seeds, you're going to have a negative outcome. And same thing when it comes to something positive. When you lay the groundwork for something that you want to achieve by planting those seeds of positivity, the affirmations, speaking into existence what you want to achieve can actually be extremely powerful. So never underestimate the power of words because words are like seeds. You get what you plant. So today we're going to cover my top 10 pro tips for navigating remote patient monitoring in 2021. So I did a previous episode way back when, and it's definitely worth an update because there have been significant changes that have impacted these codes. So I've been working with RPM programs for several years now, actually launching programs from the ground up way before this COVID-19 pandemic, and have witnessed some significant breakthroughs in RPM programs that have been very successful in various specialties. But unfortunately, with the COVID-19 pandemic, I've seen a lot of programs that are not in compliance with the RPM rules. And the thing about a successful RPM program is that it has to have a really solid infrastructure. And that infrastructure is multi-layered and very complex. And so with the public health emergency, some of the rules have been relaxed with remote patient monitoring, and we're going to see what happens with the PHE. Right now, it's still in effect, and a lot of industry stakeholders believe that it will continue through the end of 2021. So this brings me to my pro tip number 1, understand the goals of RPM. So the entire purpose of RPM is really to de-escalate care that can be done from the home. So transitioning care that would typically be done in an office or a hospital setting can now be done in the patient's home, and providers have real-time access to this data so that they can make real-time decisions about the patient's care. And the entire objective is to not only enhance that patient-provider relationship through this additional data, but to ultimately cut costs by being able to better forecast what that care is going to entail. So RPM is all about collecting and analyzing biometric data, and then that data is used to formulate a customized treatment plan and then help support that continuity of care. So as with anything, when you are reporting services to insurance and seeking that reimbursement, medical necessity is always going to be the overarching criteria. So one of the instances that I've seen of noncompliance more frequently is mass prescribing RPM to an entire patient population. So every patient has to meet the medical necessity requirements for RPM, and that has to be actively demonstrated. So you can't just have a standing order that all your patients are going to receive RPM because you think it's a good idea. There has to be an established medical necessity. Pro tip number 2, patient consent is required. So, because there may be a potential cost share to the patient, because these services are reported on a monthly basis, the patient has to be made aware in advance of the service and consent to the service. So, this can be obtained at the time that the remote patient monitoring services are being rendered, but it has to be documented in the patient's medical record. And contrary to what a lot of people may think, there are no waivers for RPM copayments or coinsurances. So, for example, if you have a Medicare patient and they do not have a secondary or Medicare Advantage plan, they would be responsible for that 20% ongoing cost share that is associated with the RPM services. That all has to be explained to the patient, or you're going to have a lot of headaches on the back end when patients are getting bills, and potentially open yourself up to a lot of legal issues if you start waiving copays and potentially enticing patients into your RPM program because there is a financial interest. And it literally blows my mind because I have this conversation all the time with healthcare organizations about being in compliance with their payer contracts, their payer agreements, and that typically includes not waiving patient cost share. So you can't just write off copays and coinsurances because you think you're doing the right thing for a patient. That can actually open up a lot of legal risks for the organization. Pro tip number 3, RPM can be ordered and billed only by physicians or NPPs. So if it's not a physician or a non-physician practitioner, then it can't be ordered and prescribed to the patient, and the services cannot be reported under that provider. The providers would also need to be eligible to report to Medicare. So I've seen some RPM programs that PTs, athletic trainers, some programs where therapists and counselors are trying to order and report for RPM, and this is not acceptable. So you do have to be either a physician, nurse practitioner, physician assistant, or some other designated NPP to order and report RPM services. Pro tip number 4, RPM is not exclusive to chronic care patients. So this used to be a thing. In the past, Medicare had only approved remote patient monitoring for patients with 2 or more chronic conditions. So they have come out and clarified that RPM can be ordered for acute conditions as well as chronic conditions. So it's not just exclusive to patients with, for example, COPD, hypertension, and diabetes. I've also seen this used in programs for comprehensive joint replacement post-op. So monitoring patients in that post-operative management period has shown significant improvements in post-op outcomes and also reductions for the need for revision replacements in patients that undergo RPM programs. So I fully anticipate there's going to be significant growth and expansion with RPM in other specialties. Pro tip number 5, there must be an established patient-physician relationship after the PHE expires. So currently there is a waiver for that established patient-physician requirement, but CMS has come out and stated that this exception will not be a permanent thing. So this is going to create some problems for those outsourced RPM and CCM companies. These are companies that partner with, say, a primary care practice and provide that RPM and CCM management as an outsourced model. These providers would now need to have some type of relationship with the provider's PCP office in order to have that established patient-physician relationship. So this is definitely going to present some challenges for those companies that have started up in the COVID-19 pandemic. So the whole idea here is that the provider would have that evaluation and management service prior to ordering the remote patient monitoring for the patient and really have an opportunity to establish that medical necessity and that continuity of care through a comprehensive treatment plan. Pro tip number 6, Biometric data transmission must be electronically collected. So I've had some clients come to me with the assumption that this data can be manually inputted either by the patient's caregiver, or the provider themselves. And the thing about reporting for RPM is that it has to be remote patient monitoring. So that data has to be seamlessly captured and electronically transmitted. Now, keep in mind, there are codes for services like self-measured blood pressure monitoring. So a lot of patients have a blood pressure monitor where they check their blood pressure at home, and those codes can be reported with those SMBP codes, but that can't be reported under RPM because there's not that electronic data transmission. And then to take it a step further, that data transmission needs to be in the electronic health record, not only for the provider to access and make appropriate treatment updates, but also for tracking and reporting purposes. So there's a minimum requirement of 16 days of data that have to be collected in order to qualify for reporting RPM services. Pro tip number 7, know the RPM codes. So stay away from CPT code 99091. This is an antiquated code and can only be furnished by a physician or NPP, which defeats the entire purpose of a remote patient monitoring program. So CPT code 99091, yes, it may have a higher reimbursement, but keep in mind it also null and voids any evaluation and management service provided on that same day. So historically, RPM was reported under 99091, but in 2019, we had new codes for RPM that are much more indicative of the services that are provided today. So I think it's just a matter of time before 99091 is deleted, but the RPM codes are going to be CPT codes 99453, 99454, 99457, and 99458. And keep in mind, RPM services are not considered diagnostic tests, so they can't be furnished by an independent diagnostic radiology facility on behalf of an ordering physician or NPP. So for CPT code 99453, this is going to be for the patient setup and education of the device. This can be provided by clinical staff under the general supervision of the billing provider. And then another common misconception is that you can report this code per device, but it can actually only be reported once per episode of care. And that period starts when the RPM service is initiated and potentially ends when the patient reaches their targeted treatment goals. And then with 99454, this is going to be the device monitoring every 30 days. And then with the device monitoring, that's going to be CPT code 99454. This is reported once every 30 days. Now, you do have to have a minimum of 16 days of data to report this code, and this code mainly helps offset the cost of the RPM device. Now, another common misconception is that people think Medicare will pay for the patient's RPM devices, and there is no upfront payment or way to get reimbursed for the RPM device, and this is the biggest hindrance for organizations that don't have a lot of money to invest in the technology upfront. But the idea is that these codes that are reported every 30 days will help offset the cost of that initial RPM device. And then we have CPT codes 99457 and the add-on code 99458 to report all of the remote patient monitoring treatment management services. So this is all of the back and forth with the patient, collecting and analyzing the data and making appropriate treatment recommendations based on that data. Pro tip number 8, understand the interactive communication requirement. So there are a lot of misconceptions in the industry about what this means. So if you look at the code descriptions for 99457 and 99458, you'll see that it requires a minimum of 20 minutes of interactive communication time with the patient over the course of a calendar month. Now, there's been a lot of controversy and pushback about this because CMS came out and said this 20 minutes of interactive communication time must be rendered via two-way synchronous audio-video technology. And the assumption has always been that this interactive communication is required, but that it would be a component of the overall 20 minutes in addition to analyzing the data, assessing it, updating the care plan, etc., But CMS came out and gave some really confusing guidance that it required the minimum of 20 minutes to be real-time synchronous audio video technology. So there was pushback from the AMA, and there's a lot of uncertainty around the true requirement. So in these instances, I always urge providers to lean on the side of caution. And if they're saying that they want 20 minutes of interactive communication with the patient, then that entire 20 minutes needs to be spent interactive communication with the patient. It's always better to be more conservative than liberal when it comes to these types of interpretations. Pro tip number 9, RPM devices must meet the FDA's definition of a medical device. So this has also been a really confusing thing because CMS has not come out and clearly stated that it has to be an approved FDA device, but they have come out and said that the RPM device must meet the FDA's definition of a medical device as described in the Food, Drug, and Cosmetic Act. But the really confusing thing is that CMS has come out and said there's nothing that requires the RPM device to be FDA cleared or registered, but that they may deem such clearance appropriate. So again, it's always better to be conservative in your interpretation of this because CMS can always come out later and say, oh no, we actually want those to be FDA approved. So I've seen some really cool sensor technology that allows for capturing multiple biometric data points. And some of these sensors are actually FDA approved, which is really neat. But I always caution providers to stay away from technology like Apple Watches or Fitbits. Pro tip number 10, RPM reporting should be patient specific. So unfortunately, this does not go without saying, but every patient should not be identical in your RPM program. So I've seen in instances where I'm auditing for RPM compliance, and every single patient is on the same devices. Every single patient has the exact same amount of remote patient monitoring treatment management services. So it has to be patient specific and it has to be believable. Not every patient is going to qualify for 99457 and 99458 every single month. It's just not possible. There's too many variables. So when I look at those RPM logs and I see 5-minute entries for every single patient, that's definitely a red flag. Also, I've seen things like daily temperature checks trying to be passed off as remote patient monitoring. Again, this is a very liberal interpretation of collecting biometric data and then reporting it as RPM. In my opinion, daily temperature checks are not going to be enough to qualify for RPM reporting. Another red flag is reporting CPT code 99458 for every single patient. Again, every patient is not going to meet that 40-minute threshold, nor are they going to have the medical necessity to support that. So it would be expected that we'd see some variation from month to month. And then, of course, across the patient population, every patient is going to have unique specific needs. So grab a pen and paper to summarize my top 10 pro tips for navigating remote patient monitoring in 2021. Number 1, understand the goals of RPM. Number 2, patient consent is required. Number 3, RPM can be ordered and billed only by physicians or NPPs. Number 4, RPM is not exclusive to chronic care patients. Number 5, there must be an established patient-physician relationship after the PHE expires. Number 6, biometric data transmission must be electronically collected. Number 7, know the RPM codes. Number 8, understand the interactive communication requirement. Number 9, RPM devices must meet the FDA's definition of a medical device. Number 10, RPM reporting should be patient specific. So it's time for this week's coding pro tip, and it's brought to you by Project Resume. When is the last time you had your resume updated? Your resume is literally your entry ticket to that next great opportunity. Project Resume will design a customized ATS-friendly resume to demonstrate your unique skills and experience. And even better, it's written by coders for coders. Make that investment in yourself today and visit projectresume.net and mention my code ALPHACODING for special pricing. If you have a coding related question and would like to be featured in one of our coding pro tips, please reach out to me on LinkedIn, Facebook, Instagram, or YouTube. So this week's coding pro tip comes to us from Arizona. Hi, Toni. I love the podcast and look forward to Mondays because of your show. My question to you is regarding reconstructive and cosmetic procedures being performed at the same operative session. We have an ENT doctor that has just started routinely doing rhinoseptoplasties and wants to make sure we are billing appropriately. What is your experience with this? Well, first of all, I want to say thank you so much for your support of the podcast. The key here is that clinical documentation has to support the medical necessity for performing both the cosmetic and reconstructive procedures simultaneously or sequentially. And as with anything, medical necessity is the overarching criteria for payment and is ultimately going to determine the billability to qualify for insurance reimbursement. So the key here to qualify for medical necessity is going to be that reconstructive element. And in order to qualify for that, there's going to need to be documentation to support that the patient has a significant physical functional impairment and that the procedure is expected to improve that functional impairment. So the surgeon has to do a really good job of carving out what's reconstructive versus cosmetic, and then making sure that they're reporting their codes correctly. They're doing some type of pre-surgical treatment planning session with the patient so that they understand what's cosmetic, what's reconstructive, and how those fees are carved out. So that is a bit of a loaded answer. I could probably do an entire episode on that, but I hope that points you in the right direction. Please remember to hit that subscribe button now so you never miss another episode. Also, be sure to drop us a 5-star rating and review on iTunes. We really appreciate your support. So this concludes today's episode. Until next week, thank you for listening to the Alpha Coding Podcast. We'll see you next Monday.
For more information about medical coding and billing pro tips, including how to hire Alpha coding experts, follow us on LinkedIn, Instagram, Facebook, YouTube, or visit our website at www.alphacodingexperts.com.